For the sake of time, we'll move on to my talk, the last talk, and then we'll go over the Q&A. In this talk, we'll go over the traumatic carotid dissection, which is a very controversial topic in terms of diagnosis, investigation, even management. First of all, I have no disclosures. We're going to go over some introduction, some of the imaging modalities and advances in imaging modality that may actually help in the decision-making process, and some of the management strategies or proposed management strategies. So carotid dissection is a rare entity. It affects 2 to 3 per 100,000 population. It can be classified according to the etiology, whether it's a spontaneous or traumatic, or according to the location, whether it's extracranial or intracranial, or specifically extradural versus intradural. Around 4% of carotid dissection are related to severe trauma. And it can occur to a blunt trauma to the head or the neck, and any rapid movement in any axis. The traumatic carotid dissection is a leading cause of stroke in the young. It presents with only 10%, which is a small proportion of patients present with immediate symptom after the injury. So the majority of those patients are asymptomatic. And the other thing is that in the context of a severe trauma, when the patients are unconscious or intubated, it might be difficult to elicit some of the clinical findings to detect if this patient has a carotid dissection. And also those patients, they cannot communicate headache or neck pain, for example. The clinical presentation, as we all know, can range from neck pain, headache, to a serious neurological sequelae in the form of ischemic event or a hemorrhagic stroke, or specifically a subarachnoid hemorrhage. Now, the concerning thing is that 80% of those patients, their stroke evolved within the first week. So the first week from the injury, or the first week from the development of the traumatic dissection. And once that happened, the mortality rate is as high as 40%. So high index of suspicion and early detection is key to manage those patients and try to prevent significant neurological sequelae. Now, in terms of imaging, we'll start with the basic. As we know, the ultrasonography is a well-known and well-described modality of imaging, especially the Doppler mode, not the B mode. The downside of that is that it's limited to the cervical segment. It's very difficult to assess intracranial dissection using ultrasound. It has poor sensitivity compared to other imaging modality, which is basically around 68 to 70%. We can visualize the mural hematoma, flow aberration to detect if there's any flow changes across the area of the dissection. We can also visualize mobile flap and luminal thrombi. This, for example, a Doppler ultrasound showing the difference in the flow aberration, or the difference in flow in the mural hematoma, which is here, and we can see the waves in this image versus the actual, the true lumen. Also, another image, when we look at some of the axial images on the ultrasound, we can see the double lumen sign, either in the sagittal image or the axial one. And those are mainly diagnostic features to diagnose the arterial dissection. But as I mentioned, the sensitivity is relatively low, and it has a limitation that it cannot detect intracranial pathologies. CTA, as we all know, is a modality of choice, especially in the context of trauma. Most of those patients, they go to the CT scanner to get the pan-CT, and we typically include the CTA, especially in someone who's comatose, as a part of the assessment to his brain or neurological function, and to see if there's any significant damage. So CT is the way to go in the context of trauma. It has very high sensitivity and specificity, as we all know, and it can be superior to the MRA in detecting intimal flap and pseudoaneurysms. And also, and I think this will probably be an evolving thing that may guide in the decision-making process in terms of management, we have the advantage of CT perfusion as well. So with the presence of a dissection, for example, you can get a sense of how much the brain is being perfused in that hemisphere, and could this be a case that I would manage medically or manage with an intervention, whether endovascular stenting or surgical reconstruction. This is, for example, the CTA showing dissection of the right internal carotid, and also with a significantly diminished flow that appears in the middle image in the mean transit time, the MTT, but there's no significant change in the volume. So CTA has this advantage of high sensitivity, high specificity in detection, and also in assessing the impact of the dissection on the ipsilateral hemisphere. The MRI and MRA is the best way to visualize the intramural hematoma, especially in the T2 fat-saturated image. The intramural hematoma can be missed if the scan is done earlier. If it's done 24 or 48 hours immediately after the injury, it can be missed. MRI also has the advantage of looking at the flare sequences as well as the diffusion weighted image to see if there is already established infarct or silent infarct, or to see if there is any areas of penumbra that might be affected by the hemodynamic change that occur after the dissection. The MRI can be superior to angiogram, especially if there is no luminal abnormality or if there is vessel occlusion, because as we know, the cerebral angiogram is a luminogram. We only see what goes into the lumen, and we don't see what's happening into the wall unless there is a compromise to the lumen. So the MRI has this advantage over DSA in certain circumstances. This is an image showing the intramural hematoma on the fat-saturated image of the left internal carotid artery. Cerebral angiogram, as you all know, the gold standard for luminal imaging. It's an invasive test. It has overall 1% or less than 1% risk of complications. We usually reserve it when there's a high index of suspicion in a negative non-invasive test. Those are some of the findings that we typically see in an angiogram: the double lumen sign and the flame sign on the cerebral angiogram. Now, one of the advances in imaging, and this is OCT basically, or optical coherence tomography, has been approved in cardiac angiography for many years, and they use it to visualize the lumen of the vessel pre and after stenting, just to determine if the stent is well placed and if there is any intraluminal narrowing or excessive endothelialization, for example. The disadvantage of the OCT, it's an invasive test. You need to do an angiogram to be able to do an OCT. You need to have an OCT imaging catheter, and you need to have an OCT analysis system. So it needs some supply to have it done. It's not unlike the readily available CTA or MRA, for example, an angiogram. It has the best resolution of all imaging. 10 times better resolution than any other imaging modality, even the angiogram, and it displays the vessel wall location and the extent of the pathology. Now, this case report demonstrated two cases that we used the OCT in imaging of the carotid dissection. So basically, just going to go out of the presentation mode to show my marker. So this is the internal carotid. Typically, you have a guide catheter in the common carotid artery, and then you have your OCT imaging catheter across the section, and then we do the special angiogram with the OCT analysis, and this is what you get in terms of imaging. So you look at the internal, the interior of the blood vessel, basically. So in this image, for example, at A, which is distal to the pseudoaneurysm that we can see here, we see the mural hematoma in that location. And in B, for example, we can see the dome of the aneurysm, and we can see some of the intramural hematoma between the intima and the medial layer of the vessel wall. And in C, for example, which is proximal to the pseudoaneurysm, which what we expect, we can see the intimal tear, and it's covered by a thrombus. So it's very fascinating how we can visualize all of these things, and we can probably predict that those things or those imaging might have a potential to guide the management down the road, especially if you have, for example, a specific size of a mural hematoma or a specific measurement of an intimal flap. This might predict in the future that those lesions will probably respond to medical management or might need an intervention sooner rather than later. And this was the second case that was demonstrated with an OCT imaging. And again, it shows the layers of the vessel wall, and it shows the hematoma and the exact location of the intimal flap. And OCT in those two cases, one of the cases actually, OCT detected another intimal flap that was not picked up by the CTA. And this definitely has a huge implication on management. For example, if we're planning to place a stent, the goal is to cover the intimal flap to prevent further flow into the mural hematoma. So if another flap is missed or not covered, this will make the chance of success of your procedure less likely. So this is, again, a novel thing. I didn't see anything or large studies about this in the literature, but I think it has a potential use in this specific entity. Now, in terms of management, management can be observation versus medical management by antithrombotic therapy. That could be either with antiplatelet therapy or anticoagulation, or a vessel reconstruction or sacrifice using endovascular or surgical maneuvers. Now, when you look at the guidelines by the American Stroke Association in 2018, this was basically mainly an update about the advances in thrombectomy and the time window of when to do a thrombectomy, but there wasn't any new statement or something that would change the practice in terms of carotid dissection. Those are the two statements that were stated, is that you can give IV TPA if you have a stroke in the presence of an extracranial dissection, and you can give an IV TPA in the context of a stroke in an intracranial dissection. But if you look back to the 2014 guidelines, basically they indicated as a class 2A evidence that the management of those patients with either antiplatelet or anticoagulation for 3 to 6 months is reasonable. So it's an option in treatment. And the duration, 3 to 6 months, is that's the usual time for the new endothelialization or the repair of the intimal flap that's within the intimal layer of the blood vessel. And also the relative efficacy of antiplatelet therapy compared to anticoagulation for patients with ischemic stroke or TIA and extracranial carotid or vertebral dissection. So it was a reasonable option to start antiplatelet anticoagulation. It has a relative efficacy. And in case of failure of antithrombotic management, then endovascular stenting primarily or endovascular repair would be your next option, and in much less circumstances, surgical reconstruction. Now, in terms of antiplatelet versus anticoagulation, when we talk about this, we have to mention the CADIS trial, which is published in Lancet Neurology in 2015. As we all know, this was a randomized trial. The enrollment was between February 2006 to June 2013. Symptomatic patient with within 7 days, and imaging showed dissection. Either it's a definitive diagnosis or a probable diagnosis. They included 250 patients. 126 received antiplatelet therapy, and 124 received anticoagulation. The primary outcome was an ipsilateral stroke or death at 90 days, and the intention to treat the group. After they did the analysis, some of the patients were excluded because in reviewing the imaging, they did not actually have a definitive dissection. So the number of patients that were included in the analysis was 101 in the antiplatelet group and 96 patients in the anticoagulation group. And the outcome is that the risk of stroke was relatively the same on both groups. It was 2% in the antiplatelet group and 1% in the anticoagulation group without any statistical difference. So they concluded from this randomized, well-designed trial that antiplatelet or anticoagulation are both reasonable options, with none of them significantly superior than the other in the prevention of an ischemic event following a carotid dissection. Another paper, 2017, published in the Red Journal, Neurosurgery. This was a retrospective cohort that basically confirmed the same finding of the CADIS trial. This patient was this study included a carotid and vertebral. It was intra and extracranial, spontaneous and traumatic. The outcomes were stroke or TIA or hemorrhage, and the modified Rankin scale on the last available follow-up, and the need for surgical or endovascular procedure as a rescue procedure. Out of those patients, 108 had traumatic dissection, 58% had antiplatelet therapy, the majority had either aspirin or dual, 26% had anticoagulation, 10% had combined treatment, and 4% were managed conservatively. And the ischemic event, again, did not significantly change between the groups. In this retrospective cohort, it was around 7% in the antiplatelet group and 11% in the anticoagulation group. Now, one of the protocols, basically this paper, they described the protocol is that every patient with a dissection, they would do an angiogram to assess the perfusion or the blood flow. If there is any slowing of blood flow that is manifested on the blushing of the parenchymal phase of the angiogram, for example, then they would upfront treat those patients with stenting. I think the concept is very reasonable, but as I mentioned earlier, that CT perfusion will probably give you the same information. For example, if you have a dissection and the CT perfusion showed delayed mean transit time and decreased flow, for example, you'd be very reluctant to start this patient on antiplatelet and send them home. They might need further observation, plus minus an intervention down the road. So in conclusion, a traumatic carotid dissection is a rare entity compared to other cerebrovascular pathologies, and in dissection itself, spontaneous dissection seems to be more common than a traumatic dissection. High index of suspicion is needed in severe traumatic injury because, as we mentioned, that only 10% of them present, and 80% of those will develop symptoms or evolve into an ischemic event within the first week. Initial management of antiplatelet and anticoagulation is reasonable. This was based on the guideline and based on a randomized controlled trial. Further evaluation with angiogram or CT perfusion might be a reasonable thing to do, and when in doubt about the prediction of if the medical management will fail or not. It's when we can use it as an adjunct thing to add to the information we have before we make the decision to manage this conservatively or to intervene sooner. And also the potential clinical implication of the advanced imaging that has gradually being introduced into our neurosurgical and neurovascular practice, which is the optical coherence tomography, or OCT. Thank you very much.